Thank you so much, Sugata. With that, we come over to the tips for cataract surgery in a diabetic patient.
Thank you very much, the scientific committee, for giving me this opportunity. Uh, Diabetes has become, our country has become the diabetic capital of the world now. And so as eye surgeons, we often come across a considerable number of patients who are diabetics. So as we all know that diabetics are 2 to 5 times more likely to develop cataract, and they form early, and they can be different morphological types. But so now the consensus, according to the studies, that early surgery is being recommended because before the lens opacities are obscuring the retinal details, and for preventing retinal evaluation and timely treatment. So according to the ETDRS, diabetic retinopathy progresses and visual acuity worsens about 20 to 50% of the cases after uncomplicated cataract surgery compared to the fellow unoperated eye. So we have to be very, very careful about this. So we need to do a preoperative counseling, which is very, very important to the patient about the expectation of visual outcome in such cases. And it's so important to have a good glycemic control and control of ocular and periocular infection, because the conjunctiva in diabetics are more prone to having staph aureus and streptococcus, klebsiella, other infections. So we have to be very, very thorough. Asepsis is important. Preoperatively, thorough ocular examination. And sometimes FFA, if it's an active diabetic retinopathy, fluorescent angiography helps, to assess the situation. OCT of the macula is very, very important in all cases of diabetic retinopathy. B-scan ultrasonography, when we can't get to see the retina, it is helpful to do a B-scan ultrasonography. And in such cases, often one school of thought is also to use preoperative topical NSAID starting about a week before the cataract surgery. So if the patient is having pre-existing DME, so previously we used to do focal and grid laser, but that is becoming less popular nowadays. And pharmacotherapy is a very, very important modality of treatment. Perioperative intravitreal anti-VEGF injection, and sometimes intravitreal steroid injection can also be given. And intraoperative, it has been studies have shown that intraoperative ranibizumab is the most effective of all the anti-VEGF drugs in practice. And intraoperative steroid injection can be reserved for those persistent and refractory DME cases, but we have to remember about the risk of increased IOP, which can be very high and devastating. A patient coming with PDR, which is untreated, coming for cataract surgery, it definitely progresses after cataract surgery. So we have to go for if possible, a PRP preoperatively, and if the view is not that good, indirect laser photocoagulation PRP can be done within a week's time after the cataract surgery. And combined cataract surgery and vitrectomy can be taken up in case there is a vitreous hemorrhage or a tractional retinal detachment of the macula. So, and a patient, sometimes, we can also get a patient having neovascular of the iris or the neovascular glaucoma. And we have to remember the prognosis is not that good in such cases. But we have to anyhow go for a prompt treatment and control the inflammation and the intraocular pressure medically, and then, inject intravitreal anti-VEGF injection, and then go for the phacomuscular surgery, and sometimes with vitrectomy. And if the angle is closed with fibrosed new vessels, then we have to go for trabeculectomy and phacoemulsification combined surgery. What sort of IOLs we should choose in such cases? A large diameter IOL for better visualization of the peripheral retina, and often in these cases they often develop severe PCO, and there's a chance of capsular phimosis, anterocapsular phimosis. So we have to be careful about that. We should make a larger axis. Hydrophobic acrylic IOL is the most preferred IOL. We can get, though, mild antechamber flare in the early post-op period. Blue light filtering IOLs are very good for such cases. Multifocal IOLs are absolutely no-no. And silicon lenses, as mentioned, we are not using anymore. And iris claw lenses to be avoided because it leads to poor mydriasis and chance of cystoid macular edema. So intraoperatively, we should go for a phacoemulsification IOL surgery. and larger capsulexes, as I mentioned, longer duration and more complicated cataracts should be avoided because it increases the risk of diabetic retinopathy progression. And poor pupillary dilatation should be managed with iris hooks and Malliging ring, BX ring. Intraoperative hyphema can also happen due to neovascularization of the iris. Photic retinopathy can take place, and these eyes have a very abnormal corneal epithelium, so they can lead to corneal epithelial defects, delayed healing of the epithelium, and endothelial cell loss is also an important thing to take care of. Specular microscopy helps to assess the endothelial layer, and endothelial protection with the visco device is very, very important. So challenges that we face are sometimes vitreous hemorrhage obscures the red reflex, which capsulexis becomes more difficult. Brunescent and white cataracts, use of trypan blue is very important. Post-vitrectomy cataract is commonly encountered. Patients who had already had a vitrectomy done. So we have to be very careful in these cases. A rapidly developing white cataract after vitrectomy gives a clue that the posterior capsule is compromised. So you should be cautiously doing the hydrodissection. Zonular laxity is another problem in such cases, and increased floppiness of the capsule is seen in vitrectomized eyes. So we should be careful in this. In center involving DME, we have to give intravitreal anti-VEGF injection and repeat injections as per the DRCR recommendations. Steroids can be also given in persistent refractory DME cases. So it's better to give it intraoperatively. So post-op consideration, we should definitely look at the NPDR cases. We should follow them up, and after 3 months' time, we should check the patient up. PDR should be closely followed up, and as I said, cornea can heal a little delayed, and post-op uveitis should be controlled, and NVI should be looked for. Prompt treatment of that should be done. Increased risk of endophthalmitis is always kept in mind, and FFA can be done to distinguish CMO. So in general, mild NPDR, no DR cases they give good results. Moderate to severe, the increased risk of progression is there. Advanced DR, sometimes even after cataract surgery, we may not be getting a good visual outcome. The visual recovery depends upon the macular status. How is the perfusion, whether this is a DME, ERM stage of the diabetic retinopathy.
Can you sum up, please?
If you can sum up, please.
So, and vitrectomy cases can be combined with cataract surgery in coexistent cataract, non-clearing vitreous hemorrhage, macular TRD, combined RD, and persistent DME. So, to conclude, diabetic patients are a unique subset of patients. They have to be, surgeons need to be aware of the difficulties and challenges during the operation, cataract surgery, and we have to optimize the retinal condition first before going for the cataract surgery. And modern minimal incision cataract surgery is the treatment of choice, modality of choice, and pharmacological therapies, they play a very safer and more effective role in such cases. And as I mentioned, patient education and counseling is very, very important. We all invite you to Calcutta next year for the AIOC.